Good evening, everyone, and welcome to the 29th webinar with Dr. Imran Lasker. We're almost at that big 30. Can't believe how many webinars we've had so far. Like always, I'll be back in the background for any support, so please use the chat box. I'll be posting the collection link in the chat box as well, so you can follow along with the cases. So there'll be two links, one for our users that can access the platform directly. And if you don't have a user on Collective Minds, you can also still go through the cases via our open link. So I'll post those links in the chat box. Please feel free to interact with Dr. Imran during the webinar session. Any questions you have, please do just put them in the chat box. There will be a CPD certificate for everyone that's attended tonight. And all you need to do is just fill in a short questionnaire at the end of the webinar, and we will send out those CPD certificates for you. So with no further ado, I'll give the word to Dr. Lasker and we'll begin the webinar. Over to you, Dr. Lasker.
So hi everyone. Sorry, I don't know if that broke off there, but I was just putting a wide connection in to make sure that I don't cut off this time. So I hope everyone's well. Sorry for the slightly late start. My fault. I'll have to take blame for that because I was talking about my cat. I'm going to do a public service announcement, by the way. I just got a cat. Never had a cat before in my life. Never had any sort of pets. And apparently, lilies are very bad for cats. So if you've got a cat, I've been telling everyone, don't let it go near lilies because apparently it can kill them. And thankfully, my pet's alive, but it was a close one. I had no idea. So anyway, I'm going to keep the chat open as usual. So you guys can chat to me during this. You can ask me about my cat if you want. I don't mind. And we're just going to go through a few of the cases. I just want to make sure that everyone can see my screen. Everyone should have a link now to the cases. If not, just drop a message in the chat below, and we should be able to sort that out for you. And then now what we'll do is just go through some of the cases that we've got. And we've got quite a few. I don't know if we'll be able to get through all of them, but the way this works is I just go through our normal day to day. And then I'm always thinking around in the background about decent cases to pick up. And this particular month, there were just quite a good few cases. And I had a few that I've been saving up for a while. So I put them all on here just on the off chance we can get through it all. If we can't, then, fair enough. Like we'll use them for next time. So, right. So, can we just get confirmation that everyone can see my screen? Just someone out there just say yes, and I'll go for it. Yes, good. Okay, cool. Ah, Raw. Thank you. Welcome. Okay, so what we'll do is have a look at this first chest X-ray, and I always say like, go, Collective Minds is really, really good, especially if you do that little download button. With the plain films, it's not so bad because they're just the plain film. With the CTs, it does make a big difference to how quickly the cases upload and all the rest of it. But let's have a look at this chest X-ray together and see what you think. Do write your answers if you can see any issues at all. If not, don't worry, I'm going to go through it all together. So let's say this patient fell over and we're worried about this patient having a pneumothorax. And so what I always do when it comes to pneumothoraces is have a look at the lung apices and just make sure that the lung apices are completely normal, right? So what you want to do is have a look and see whether there are any lung markings going all the way through to the edges. This one, I'm not so sure it is. So we're going to zoom in and just kind of have a look a bit further. And I don't think I can say that I can 100% see that any lung markings there. So you put a little square there and it just feels like there's not much there. But if you look a little square there, you can see some lung markings. So then if that's the case, where would the edge of the lung marking be? So this person feels like straight away they've actually got probably a small pneumothorax. And then what you need to do is start to look for like a lung edge. And the way to do it is to sort of just have a look at the ribs and just follow along and see if you can see another line that's not a rib. And this is going to be subtle, isn't it? But can you see that there's sort of a linear line there that makes you feel that this could be a lung edge? So there could potentially be a small pneumothorax, maybe even coming down like this because there's a complete lack of lung markings. But some of you may have noticed that while I was doing that, if you look at the posterior aspects of the ribs, they don't look quite right either. So that one, maybe you could say that passes. That looks okay. This one, can you see that? It kind of does this sort of jaggedy thing, like a little, but like hands kind of shaking each other's hands, but you shouldn't really have that there. Looks like that might be gone as well. Can you see that one? That's a posterior aspect of that one. This one, that definitely doesn't look quite in line, does it? I just feel like there could be a few rib fractures there as well. So what we'll do, we just kind of draw around. So you go like one, two, what do we know what? That's going to be three. That's going to be four. That's going to be five. And that's going to be six. There's multiple, like six fractures. And you just want to make sure there's no other fractures. If you've got like three contingent, like three in a line, then you may be looking at a flail segment. I don't think you can say that there's a flail segment on this particular X-ray at all, which is good. And then yeah, someone said it as well. Like I do think I agree. Like if you look at that costophrenic angle, that doesn't look quite normal. So let's zoom out. Let's zoom out. That costophrenic angle looks okay, and that costophrenic angle just looks a bit sort of blunted. You can't really see it so well. So this looks like, yeah, they've fallen over on their right side. They look like they've got a small pneumothorax on the right apex, and it also looks like they've got multiple fractured ribs and a small pleural effusion. It could be a hemothorax. You may want to do further imaging. So we could move on, but actually there was something else on this, and I wonder if anyone can see it. I'm just gonna have a quick, yeah, exactly. Capital letters as well, or do you leave your caps lock on? For those that haven't seen it, there is a massive clavicular fracture. Can you see that? It's right in the middle third. So that's the clavicle. That's the middle third. Then you've got your lateral third. And so this is actually very common. This is pretty much where most people get fractured around this area over here. Oops, what's that? But yeah, that's where you normally get a fracture. It's going to be the middle third. The medial third, if you've got fractured the medial third, then you are talking about quite a hefty bit of trauma. A lateral third can also get fractured as well. And sometimes you get a bit of ACJ dislocation as well. But this one, I think what you have here is a significant fracture and displacement of the middle third of the right clavicle. Okay, good. So we've got pneumothorax, multiple fractured ribs, small pleural effusion, and a fracture of the right clavicle on the very first case. Hopefully that wasn't too hard. And like I said, I always try and make sure we've got a kind of a good breadth of cases so that everyone gets to sort of you get different sort of abilities whenever we do these talks. Okay, let's have a look at this one. And this wasn't trauma. They came in, query perforation. They've got a bit of abdominal pain. And often, I mean, even now these days, we will still do a chest and abdomen x-rays in the first instance to see what's going on. So in this context, you want to look under the hemidiaphragms and make sure there's no evidence of any air under the hemidiaphragms. So this one, it does look like there's air, but that's probably going to be the fundus of the stomach. And this looks like some of that bowel is kind of interposed and in front of the liver. And that's something known as Chiari-DT syndrome or something, where the bowel kind of just interposes between the liver and between the liver and the diaphragm. But not necessarily, that's not going to be free air because it looks far too well contained. Let's have a look at the lungs themselves. Let's have another look at that lung apex. So we've kind of got that last one in our mind from before. We'll have a look at this. And actually, this lung apex looks okay, and this lung apex looks okay as well. And if you don't believe me, let's zoom in and really try and do that sort of square thing. I always say, try and do a little square like this, and have a look. And you can see lung markings going all the way to the edges. And if we do the same on the other side, lung markings all the way to the edges. I don't think we can see a pneumothorax at all on this anywhere on the study. Now, I always do check areas as well. For those that don't know, always look at the costophrenic angles. And the last costophrenic angle we had was blunt. This one is not. Shouldn't the coexistence of pneumothorax and hemothorax lead to an air fluid level? Yes, it depends on how big it is. So that depends on how big it is. So that was probably going to be a very small pleural effusion, which would therefore only get like the tiny corner. And then, you could still have a pneumothorax right at the top. Pneumothorax don't always be at the top here. Sometimes you get like a collapsed lower lobe, depending on what part of the body's injured. But with this one, with that last one, not this one, with that one, I suspect it was a small apical pneumothorax, and it kind of made sense because you had all these fractures of the posterior rib, so it's probably one that's poked that balloon. But then there was a little bit of bleed, and they ended up having to have a blunted costophrenic angle. It doesn't always have to be a bleed. Sometimes it's irritation. The general injury can result in a small pleural effusion as well. But yeah, if it's big enough, of course you get an air fluid level. But I think that was too small to have an air fluid level. Yeah, someone's mentioned something they've seen on the. Did you see it on the chest X-ray? Someone said something. Okay, well we'll come back to that as well. So Hyla, they look okay. But we're going to come back because we were doing this X-ray because this patient said they had abdominal pains. We're looking for air under the hemidiaphragms. And actually, this bowel doesn't look quite right. You can see maybe a bit of fluid level in there. That's not something to really write home about, but the bowel does look a little bit dilated at this level. So when we come up to the abdominal film, you can see actually the rest of the area looks okay. That bit of bowel that we're looking at, it doesn't look too bad. But when you actually look at the lower abdomen around this area here, you can see that there's some enlarged air-filled bowel, right? And then you've got to think, okay, is this large bowel or small bowel? So small bowel is going to be generally in the central abdomen of the abdomen, and the large bowel is going to be on the outside of the abdomen. So this feels a bit more central. And actually, when you look at it, it does feel like these lines go all the way across. And when they go all the way across like that, then that's going to be valvular convergence and therefore be consistent with the small bowel. And therefore, we are looking at a small bowel obstruction. Now, at this point, I don't think, sorry, I don't know why the emojis come up. At this point, I don't think we can say there's any airfield, any free locules of air. If this is normal, then my caveat with reporting is, or I always say there's no air-filled bowel obstruction because there has been one occasion where I reported no bowel obstruction and it turned out it was obstructed, but because it was full of fluid, you couldn't see it because you have to remember when you take X-rays, all you are looking at are the interface density, the densities, in difference in densities between different parts of the body. So you do need to have a difference between like soft tissue and bowel, and the only way you can do that is by having air. So I always report like no air-filled bowel obstruction. But in this one, I think that there is air-filled bowel obstruction, as evidenced by the right lower abdomen and what looks like the valvular gonadventes going all the way across. And it just so happens, if I've ordered this correctly, we do have the follow-up CT. So I'm going to let that download just for a couple of seconds. Oh, it's actually going quick today, maybe because I've got a wide connection. Um, so look, that light went all the way across, probably depending on my connections. It's very, very quick today, and that makes things a lot smoother. Like when you do, when you are doing presenting like this. I personally use Collective Minds for my teaching for radiology seminars. If you are interested in signing up to radiology seminars, we do have quite a few courses available. And actually, if anyone's interested, we currently run an MSK community, which is coupled with two fellowships, spine and knee, and we are going to be launching a neuro community and fellowship very, very soon. So if you're interested, do come along and have a look. But Collective Minds have been our go-to people for all of our kind of needs when it comes to teaching and stuff. So I'd highly recommend it. Okay, let's have a look. So this is the patient that we saw earlier, the plain film. We come up to here, and you can see there is a bit of sort of bowel sort of sitting right adjacent to the liver, like we saw earlier. Coming further down, that stomach looks a bit dilated, doesn't it? It looks like a bit large. And coming further down, and now you can see multiple loops of dilated small bowel. How do I know small bowel? Like I said earlier, it's kind of very centrally placed. And as you scroll through, you should be able to see these linear lines going right across. So these are the valvular column that we're talking about. Now, what we have to do is try and figure out, okay, so you've got someone with small bowel obstruction. What could have caused this small bowel obstruction? Or can we find a transition point to try and guide the surgeons to know where to go when they're going to try and help this person if they want to kind of be focused on what they're doing? So there's a couple of ways to do it. And the way I normally do it is just have a scroll through and look to see where there's any sort of fecal material located within the small bowel. Because what happens with the small bowel is you get kind of the food going through, and the fluids kind of taken out, taken out. But usually it's in the kind of colon where the last bits of fluid are taken out, and then you have that kind of fecal material appearance, which is sort of bubbly stuff sitting within the bowel. So you've got something like that, then somewhere along here, then you know that the bowel contents have slowed down at that particular point, and therefore your obstruction will be somewhere very close to that fecal area of small bowel. But this, I don't think you can really 100% say there's any small bowel small bowel fecal sign anywhere actually. So it's going to be hard. We're not going to be able to find a transition point like that. The next thing I'll be thinking of is where there's any obvious hernias. And I've seen this happen where when we're going through cases, when I'm doing the teaching for 2Bs anyway, the 2B exams, which are the UK FRCR exams, some people just kind of go up to here and then start going up and down like this. But what you really need to do is go to the very, very end and make sure there's no inguinal hernia, no obturator hernia, or anything like that. But that's not the case in this situation either. So it does feel you might have to do the long way around. And with small bowel, it really is a long way around. And I sometimes go like this, going all the way along like the duodenum, going all the way along like this, and then you kind of lose it and you're not entirely sure. So then what I do is I try and find a dilated loop of small bowel and just follow it down. And I don't know if anyone's got a better way of doing it. I'd be quite interested. I've been doing this for a long time now. But I feel like that's probably the best and quickest way for me to find where the transition point is. So for example, this one here, let's go from here, just try and figure out. So if we go from here, just follow it down. And this is what I do. I just go down this way, keep trying to follow more bowel, keep following, goes this way, keep going, goes this way. And then look, can you see that? It kind of gets really thinned out there, doesn't it? And then becomes normal. So something's happened here. It looks very, very low in the right iliac fossa. So the next thing you want to do is use the NPR function, and I'm going to sing its praises. The NPR function is brilliant on this, isn't it? It's just like using a normal workstation, but all through your browser. And sometimes when you see that, you know how we saw that kind of sudden taper of bowel, you might just want to scroll through and just see whether there's any twisting of bowel. Sometimes that kind of gives you a sign. But I think that could be here. Can you see this? So you got that. and it feels like it kind of twists on itself just there and then becomes really large. And that's another way to do it. If you can't see it actually, you can sometimes go chronally and just see if something sticks out at you. And to me anyway, it was it was that area there where it kind of just sort of twists like this. Look, like that, like a volvulus. So it does feel like it's twisted. So maybe some sort of internal hernia of some sort has resulted in a small bowel obstruction. Now, that's something you need to mention. That say, look, there's small bowel obstruction. It looks like there's a sharp transition point located with the right lower abdomen. You probably want to say the slice number if you can. If you want to do coronal, then just say coronal or just say axial images. And the next important thing to say is there's no evidence of any ischemia or perforation at the time of the study. And from what I remember, there isn't. Now, something did kind of go past my eyes, is that both these ureters look quite dilated, don't they? Just follow that down, all the way down. What on earth could be causing that? I can't really see anything that could be causing that, but it does look like they're dilated, don't they? So if you come up to this ureter on this side, that ureter does look a bit dilated, does look slightly hydronephrotic, but I also don't think that the urinary bladder is all that distended because usually you get a really distended urinary bladder and then you get dilated urinary dilated kidneys. Anyway, they have to. You could recommend checking the renal function. In this acute phase, you probably want to be dealing with the bowel obstruction, and then later on, you could do an ultrasound to make sure that those kidneys have properly decompressed and stuff. So, yeah, interesting case and a bit of a follow-on from the X-ray. Right, let's have a look at this one. And I think yeah, let's go through this one first, and then on the next. So, oops, what's that? I don't know what you're talking about. Go away. Right, so let's have a look. So this chest X-ray. Okay, so this chest X-ray. What are we thinking here? So they're kind of slightly rotated to me. I think that is a spinous process just sitting there. That's going to be the medial edge of the clavicle. That's going to be the medial edge of the clavicle, and it all feels like it's all moved that way, doesn't it? So they must have like rotated that way. So we do have to be aware. I should probably gone that way because it feels like that highlight is going to look a bit larger because you kind of on fast that way around. And then the aortic knuckle goes that way and probably down like that. So you don't want to call too much in this particular area over here. And then you want to look at the lungs. The costophrenic angle is slightly, you can't really see what's going on there. And we want to have a look at the rest of the lungs. So apices, how do they look? So my check areas, apices, looks good, doesn't it? Apices look good. Don't get fooled by this. I've actually been called in the middle of the night, someone telling me that that's a pneumothorax. Don't fall for that. Just follow the line all the way around, and then you'll see that's a scapula. Same on the other side. It's not a pneumothorax. It's a scapula. Not going to get caught out by the clavicles this time. Lung apices, no pneumothorax. Hyla look okay. Can't see the costophrenic angles. We're about to say everything's okay, but yeah, someone's mentioned that actually when you look around here, this doesn't look quite right, does it? It looks like there's a density difference between this area and this area, and this looks like a very nice, well-defined line, and then it gets very, very sort of dark or white as you go further down. But that right heart border is maintained. So if you've got a shadowing around this area and a right heart border that's maintained, then you're probably looking at right lower lobe consolidation. And big lung volumes, yeah, I think so. They are. I mean, it's an AP film, but yeah, I guess I would go with that. Maybe the hematopoietic diaphragms are slightly flattened. I mean, I feel like you could tell this person's a slightly older patient. I feel you can just say that just by looking at this, the way the body is. But now let's have a look at the follow-up CT scan and see what that is saying. So well done, yeah, you picked that up. And actually, contrary to so what we didn't see is what was going on the left. And so actually this is going to be the poll quiz. We'll have a look through and you guys can answer as we go through. So let's go from the very, very top. This is clearly a contrast enhanced study. Scroll all the way down. I always do one scroll through whatever window I have, go all the way down like so. And actually that's okay, isn't it? So now what we'll do is press 1, 2, 3, 4. So number 4 will give you the lung windows. Let's go from the very, very top again. And we've got a little bit of apical scarring that happens, I guess, as you get older. The apices are not as well aerated. I'm about to say hydrated, aerated. You do have some bronchiectasis, don't you, around here? Quite dilated airways, a bit unusual. And thick, thick bands of atelectasis all over the place. That looks like could be a bit of consolidation or scarring located in the posterior aspect. So let's come further down, more bands of atelectasis. And there, you've got this quite significant consolidative changes located over here. But then over here, it looks like it's actually the right middle lobe that's got consolidation, doesn't it? which is unusual because we're normally taught in radiology anyway. And this is definitely the follow-up, by the way. And I don't think anything's changed between the two scans. But if you can't see the right heart border, then you're looking at right middle lobe. But on that X-ray, you definitely could see the right heart border. But on the CT follow-up, this ended up being what looks like a right middle lobe pneumonia, doesn't it? But then, okay, let's look. Someone's saying trachea looks a bit large. Yeah, I guess so. I mean, they could have just taken a deep breath in, but yeah, I guess so. It is slightly enlarged. I mean, the airways around this sort of area over here, like this area, it should really sort of taper down. It just doesn't seem to ever taper down. It keeps going, and there's really big sort of spherical, cylindrical things going all the way down. So I think there's going to be an element of underlying bronchiectasis. But yeah, the main thing is they've got consolidation going on here. I don't know if you've got any lymph nodes. I can't remember if any lymph nodes on this. So yeah, I think we've had a look at the someone we've had the poll, and yeah, everyone's correct. So it said all of these can cause consolidation except, right? And so lymph nodes are just lymph nodes that don't cause consolidation, but blood, pus, and lymph can all cause consolidative changes. And for those that don't know, I quickly say I always try and imagine it to be like when you go to Amazon and there's actually, I won't go to Amazon, obviously, but I've been buying a jiggler. Okay, let's have a look. So if we go to, if we type in kids water bottle with straw. So these guys, I'm not going to show, I'm not going to buy one now. I buy so many of these. My kids always seem to ruin these things, but especially ones with glitter. That is the way I always describe the lungs because you've got this kind of central bronchus, and then when you fill it up with fluid, then the actual straw never gets filled up, and it's the same as the lungs. So the lungs get full of fluid and gunk, but the central kind of airway doesn't get full of fluid, and that's why you get this sort of air bronchogram appearance. It's exactly the same kind of idea and concept. Well, in my mind, anyway. It's just the way I think about these things. Okay, so let's go on to this case. So this patient fell down the stairs, like the poor souls that this happens to. I don't know if it's the case anywhere else, but I remember when I did the orthopedics. Well, I didn't do the orthopedics job. I was a surgical trainee, but the orthopedics guys were near us, and I remember when it snowed and it was icy, they were busy, man. Like every elderly person who should not be going out to empty the bins decided to do it, and they fell over and really got themselves hurt. Anyway, some random memories. So I've got a really sore throat, so I'm really sorry about having to keep drinking fluids right now. Okay, so let's have a look at this particular X-ray. So I always make sure I have a look at the trabecular pattern, and I really genuinely zoom in because there was a case where it was literally the trabecular pattern that gave away there was a massive metastasis. So just have a look at the trabecular pattern of the bone, and I make sure it's one of the first things I do because it's going to be the last things that most people look at. And for me, if I don't do it quickly, then I'm probably going to forget. So I make sure that I do the kind of things that are a little bit less obvious. Have a look at the trabecular pattern. Make sure it's all nice because if it ever looks like it's kind of feces right upper quadrant. Okay, yeah, good. Okay, well, okay, cool. So we'll have a look and make sure that the trabecular pattern's all good. If it starts to look like there is a discrepancy in that or kind of a slightly sclerotic line, you may be looking at a sclerotic fracture. And then this side, I think the trabecular pattern's quite good. No evidence of any fracture. Some people would say that looks like a slight cam deformity. It's not that bad, but it does look like it's a bit kind of less spherical on that side. So there could be some impingement there, I guess. But I don't think that's the point in this particular X-ray. Let's have a look at the rest of the bones. So bones look okay. Look at the lesser and the greater trochanter. Sometimes you get avulsion injuries. Lesser trochanter is definitely not good news. An avulsion injury there probably is a sign of something going on in the pelvis, like a tumor of some sort. But that's not the case here. Greater trochanter looks okay. You can get anterior, inferior iliac spine avulsions, get avulsions around these areas as well. That's where the hamstring origins are. And then you want to be looking at any avulsions around here or here. Look at the trabecular pattern over here as well. And someone has said feces in the right. Yeah, so that does look like that kind of bubbly appearance is what I was talking about with the fecal sign. And I am very hesitant. I know people will have cases where that ends up being a massive tumor, but I think this going to be very, very rare. Over the years, I'm still looking for that case, which looks like a bowel pattern, and I'm sure someone's going to say they've got one. It hasn't happened to me for or ever so far. But with this, I'd have to have a really high threshold to say it's not not bowel. But this, like, okay, so someone has said, and exactly right, there are what looks like fractures here, isn't it? So if you go along this way, can you see that doesn't look quite right, does it? And that doesn't look quite right, and that doesn't look quite right. And maybe even here, but that looks like could be old, but these look like fresh fractures, really big superior and inferior pubic rami fractures, which is great. Exactly right. But the other thing is that if you look at the kind of soft tissue density over here, this one looks a little bit more dense. I don't know if people can really see that. And that's not very usual. I normally have like a dense spherical thing sitting right in the middle. It may have some bowel pattern there, but this just doesn't look quite right. It just looks very, very off. It looks like something else is happening here. So, yeah, lo and behold, you're exactly right. So we went and got a CT scan. They want to characterize a fracture. And let's do the download and have a look. So we go from the very, very top. Clearly, they're an older patient that got some atherosclerosis, a bit of degenerative changes in the lumbar spine, coming down to where that fracture is. Yeah, quite a hefty fracture there, going all the way down there. This is definitely an old fracture there. Looks like an old fracture there. But there was going to be this thing here. So we can go to soft tissue windows and straight away, exactly. Yeah, exactly like you saw in the X-ray. There's clearly a very, very, very big mass-like structure that's causing mass effect this way, pushing the urinary bladder across. And you could see that on the plain film. You could definitely see it. So you have to think about what it is. It's on the pelvic sidewall, and the context of such a big fracture, this has to be a really, really big hematoma. They've got an intrapelvic hematoma as a complication of that fracture. And actually, now when you look back, you can definitely see that there was something, it's not just a fracture. And the problem is that, sometimes they would say that, oh, patient's stable and we just deal with it in the morning. But with this person, you're now concerned that they are going to become hemodynamically unstable with such a big fracture. And because this is a non-contrast study, we don't know if they're still bleeding. They could still be bleeding right now, and we wouldn't know. So you need to bring them back. Well, depending on the clinical concern, but I'd be concerned anyway. And then I would suggest that doing a contrast study is the best way forward to see whether they're actively bleeding, because this probably needs to be dealt with sooner rather than later, because otherwise, on top of the fracture, become hypovolemic and get very, very sick indeed, but really, really bad. Okay, so well done. I think a few of us picked it up on the X-ray, which is pretty good actually. Right, so let's have a look at this one. Let's download these and take another support. I'm going to keep this open so that I can print between cases. Right, so this looks like a CTPA to begin with, and we've also got abdo-pelvis. So what we need to do is just do one scroll through all the way along, all the way along, all the way along, and all the way along. Okay, and if anyone's seen it, go for it. Good. What I'll do now is go for the abdo-pelvis and go all the way down, all the way along, all the way along, all the way along, like so. Okay, good, good. All right, fine. So what we'll do is work from first principles and have a look and see what's happening. So when we do CTPAs, we're doing a CT pulmonary angiogram. So everything's going to be, all the contrast is located within the right heart. And actually, if you go to my YouTube channel, there's a really, really interesting case which I got where they had a PE, but what happened is that they had a patent foramen valley, and it was a paradoxical embolus. Anyway, go check it out. It's really cool. It's a really cool case. I'm putting more interesting cases on the YouTube channel soon as well. But this one, it does look, it's a CTPA, and we're looking at the heart. And it does look like contrast is on both sides of the heart, but coming further up, it was this I felt as though, I mean, actually, I think one of the Regis might have missed this. I might have got that wrong, but I think this one would be missed by someone on the first sort of run. Kind of scroll through, and have a look around. Maybe you can see it, maybe you can't. We're looking for a PE. And one of the ways to try and help you is, if you're not sure, is to do this. Is go to MIP and then put this up. And then also you might need to window a bit because it does seem very bright, doesn't it? And then scroll through and see if you've got any kind of abrupt stop of any of the vessels. So let's wait for that to catch up. I've probably done it a bit too big, to be honest. Let's go 10. And it's around here. You feel like, okay, let's get to this point here. You can see that looks like the caliber of that is a bit smaller than it should be. And so that is where you think, okay, I think this person's got an underlying pulmonary embolus. And now when you come back to here, you can go back to your windowing and have a look. And that does look like the caliber of that pulmonary artery is just a bit smaller. So that must be a PE. They clearly got PE, right? So then you think, okay, well, we've got the abdo-pelvis. We probably should look and see if they've got a DVT, right? So let's have a look through and see if we can find one. IVC is going to be here. Carry on down, carry on down. It looks pretty flat, actually. So maybe they're a bit dehydrated. Probably need to be hydrated on some level. Keep coming down, and then can you see that? It suddenly gets really fat, like really, really big. And for those that do ultrasound, when you're looking for a DVT in the leg, one of the signs or one thing to do is to see the blood clot and try and push. And if it's non-compressible, then you know there's got material in there that's a blood clot. And you can see the caliber change, right? So this is pretty flat, pretty flat, pretty flat, pretty flat. And then suddenly it has a sort of kind of filling defect sitting right in there. And carrying on down, it goes down the left common iliac artery, all the way down here, all the way along. And I feel like it continues to go, continues to go. If you're not convinced, look at that one compared to that one. That looks pretty well contrasty. That one, not so much. Coming further down, it just feels like this is a really big blood clot. I think you might be losing it just here. You can't really see the rest. But anyway, there's a really, really big DVT going along that sort of femoral, along the external iliac artery, and then coming up to the common iliac artery, and then into the sort of more proximal aspect of the IVC. And that's probably where all this is coming from. So yeah, I think that was quite an interesting case, and not one that you often see because usually when you do CTPAs, you just do the chest and then you move on. Okay, cool. So let's have a look at this one. I'm trying to remember what this is. Give it a second. Take some water while I can. Okay, right. So you guys have the link to this. Let's have a look all together and see what's happening. So this was, okay, so clearly, can we tell what kind of scan it is from just looking at it and any other clues? Scroll all the way to the bottom and all the way back up. So in reality, what's happened here is that they've rotated it post-production, but actually they were like this, and the table's down here. So if you do that, then there's probably going to be CTKB. So looking for a renal tract calculus on this patient, and if I remember correctly, this is right loin to groin pain. So coming down, that ureter looks okay. The actual collecting system looks okay as well, because if you look there, that's your collectors with lots of fat there. If you lose the fat interface, then you are probably looking at some sort of hydronephrosis. That's ureter there. We'll follow down, and it may get a bit difficult to follow as you go all the way down, all the way down, all the way down. It's hard, isn't it? It's hard to really see it, you know. And in fact, recently I heard about someone that it was what looked like a phlebolymph turned out to be a renal calculus, and so I've been a bit more careful to follow these things all the way down. And sometimes even then you might need to do an IVU, CT IVU to make sure. But this one, they've got a calculus there, but coming further down, there's no other calculi. It doesn't look like there's any calculi anywhere else, but they've still got this pain. So we've got to try and figure out what could be causing this pain, right? So right side of pain, it could be cholecystitis, and that's going to be the gallbladder around there. It doesn't look like there's much going on, so that's probably going to be okay. Pancreas, where's the pancreas? It's hard to see. Okay, let's get rid of these emojis again. Pancreas is there, going all the way across the leaf-like structure. Looks okay. Doesn't look like there's any enlargement. Left adrenal gland. So someone's saying left adrenal gland, small calculus. Yeah, so there is a small calculus in the left kidney. I don't think that's going to be causing their pain. They're coming with pain. And adrenal gland is going to be this V thing here, isn't it? That one there. And then that right one is there. And actually, I think they look okay, like nice, slight, like little V's just sitting there, like victory signs. But I don't think I can see, unless you think about this bit here, maybe that's what that is. Is that coming from the kidney? Let's have a look. Maybe that's what you're talking about. I could admit I did not think much of that. So let's go coronal. Is that, yeah, it might be part of the adrenal. You're right. Okay. So there's probably is an adrenal nodule just sitting there as well. Interesting. Okay, cool. So then we've got to do, I mean, that's not going to be causing the pain. I don't think it's going to be causing the pain. So we've got to go for the bowel all the way up. If you kind of lose it, I'm going to use my mouse to follow, 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 follow. Feces going that way, feces going this way. Oh, it's gonna be tough to find. Oh, there it is. This way, this way, this way. Oh, it's coming back down on itself. Then goes this way, coming up. This is going to be the descending colon. We're at the splenic flexure, and then we've got to go all the way across. Oh, going all the way across like this. Okay, everything looks okay. Oh, actually, it does look like there could be some fat stranding. Can you see all this? This is all this fat. Fat should look like this, this, and this. This just looks cloudy. It doesn't look good. But then there should be an appendix or something, isn't it? But I can't be 100%. There's an appendix, but this feels a bit like a spherical thickening with some surrounding fat stranding. And these look a bit spherical as well. And these are lymph nodes. Okay, that looks like the terminal ileum going this way. The terminal ileum looks okay. I feel like it could be cecal pole sort of malignancy of some sort. So if there could be a malignancy, next thing we'll do is press 4, make sure there's no malignancies in the lungs, and then go to the bone windows, which is 3, and try and see if you can see any sort of metastatic disease anywhere. I don't think we've seen anything metastatic, but I'd be concerned with right iliac fossa pain like that. There is some sort of underlying malignancy located within the cecal pole. Right. And so they got brought back for further characterization of the potential lesion located within the cecal pole. This should be the contrast enhanced studies. Going all the way down, right to the area of interest. And there you go. Can you see that? There is a gross thickening and like irregular, potentially necrotic area located with that cecal pole. Probably a few prominent lymph nodes, a bit of fluidity, a bit of fat stranding around there as well. And actually, the post-contrast has revealed a few lesions within the liver. So you've got one lesion there, and you've got one lesion there, and a few smaller lesions in other places. Now, obviously, in the context of a malignancy, you could be concerned that this could be underlying malignancy as well. But actually, when you look at it, this one, especially on the outside, has got this sort of nodular, hyper-enhancing contour to it. And I think that could be the same for this one, a slightly enhancing contour to the top there, a bit on the outside as well. Very well lobulated, right? And very well defined. Doesn't look like there's very much soft tissue density to these as well. Oh, left adrenal, yeah, you're right. There you go. There's your left adrenal gland. That does look big as well. It does look like it's enhancing. So probably do need to do. I wonder what you could do actually. You could do the pre-contrast. This would be contrast and maybe delayed, or just do a full adrenal study. These are probably hemangiomas. Smaller ones are a bit harder to characterize, so you probably do want to do further investigation. There's definitely what looks like a cecal malignancy located within that right iliac fossa. Any other lymph nodes anywhere else? No, definitely not. So I don't think we've got any other lymph nodes. And yeah, like you said, there is a larger left adrenal gland as well, which will need to be further characterized. It could be involved. It could be. We won't know. But everything else was okay. But quite interesting case. So it wasn't a CTKB, and you'll notice that this table is now on their back. So they get to lie on their back for this scan, the follow-up scan. Okay, cool. So that was case number 10. Let's go for case number 11. I'm really sorry about the voice, man, honestly. Okay, so I'm going to leave that quiz open for us while we take a look and see what's going on. Oh, what happened here? Can I reload? That was weird. That's never happened to me. Maybe something to do with my computer. How many things I've got open at the same time? Okay, so we've got a few answers coming in. One answer coming in. Okay, let's have a look together. So we've got a CT abdo-pelvis, and we're going to try and figure out what's going on here. So let's go from the very top. So this is definitely a contrast enhanced study. Contrast sitting within there. And it does look like the portal vein is slightly brighter than the aorta, so we're probably looking at portal venous study. Let's do one scroll through, all the way down, 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 like so. Okay, good. So, what have we seen? What are we thinking? So, bit of atherosclerosis, they've got a slight scoliosis to the lumbar spine, few renal cysts, and actually some of this bowel looks a bit dilated, doesn't it? So what I'll do is look for that fecal sign, see if I can see any feces within any of the small bowel anywhere. And I can't see any feces anywhere. And then I'll start looking for any sort of obvious hernias. To me, that looks like a hernia, doesn't it? Now then the question is, what kind of hernia is? And so what we can see here, I've got a few answers here. Good, thank you. So a few people, yeah, so some people are saying inguinal hernia, some people saying obturator. No one's saying obturator. Someone's saying Richter's. and a few people are saying a femoral hernia. So with the inguinal hernias, right? So generally speaking, they go along the inguinal canal, which would be this guy over here. So that's the inguinal canal there. And actually, that looks pretty empty. Goes along like this all the way down. So that's going to be inguinal hernia. And then obturator hernia, you'd be looking at sort of the adductor muscles and seeing whether there's any sort of poking a bowel through there. So it's not that either. They are older, and this is would be an older patient. Now, Richter's hernias would be just part of the bowel wall. So like it was just a bit of the bowel wall that's through, but the rest of it's okay. But this looks like the whole bowel has gone through, poked in, and then it's coming out all dilated after. So this can't be just a small part. And so then what you're looking at is a hernia that's sort of medial to the vessels would therefore be a femoral hernia. So this would be a femoral hernia that is causing a small bowel obstruction. Again, important caveats are going to be no ischemia, no perforation on this particular patient. And then you could do the rest of it to make sure there's nothing else going on. But with the point of small bowel obstruction, this is going to be most likely a femoral hernia. And I think people went for inguinal. Got me paranoid now. Let's have a look. Why do people go for inguinal? So if you go down here, you've got to look for the inguinal canal, right? And if you're not sure, try and follow the other side. So you know that this side, that's going to be the inguinal canal going all the way down like so. And that's where you get a bit of fat and stuff, right? This one, you can go like this, go all the way down, and it just seems to be empty. And this is just kind of away from it. So that's why I would say that this is a femoral hernia. Okay, cool. So let's stop sharing. And well done, everyone. Thank you for getting involved on that. Ah, now I don't know where I am. Okay, so I'm going to guess at case 10. Sorry if I'm going to get back on myself. We'll find out quickly. Oh, we've already done this. Okay, so then that must mean we're case 12. So because it restarted, I've lost where I am. Okay, let's have a look at this. Okay, CT abdo-pelvis. Looks like it's going to be portovenous face. And you got your portal vein there. No, portal vein is where here. And that definitely looks brighter than the aorta, right? So therefore, this must be a portovenous phase image. Let's scroll all the way down, scroll all the way down. It does look like there's a fair bit going on, doesn't it? Oh, God. Yeah, they come down here and come down here. Okay, good. So what have we seen? What have we seen? Let's have a look. So first off, this person looks like they've got something going a bit off with the that pancreas. So that's your gallbladder, yeah. And then that's going to be your liver. Kidneys look okay, and that's your pancreas. Can you see that? And it just feels like there's something else going on here. So, like what previous bout of pancreatitis, maybe it's some sort of collection. Be a bit concerned though. It doesn't look like collection. It's a bit irregularly contoured, but definitely separate from everything else. And I can't see any enlarged lymph nodes. If you're looking for any circles anywhere else, can't see anything like that. Okay, fine. So then what we'll need to do, and someone said, yeah, exactly. So now we're going to come further down and almost a bit like that last scan that we had the fracture. It looks like we've got a pelvic bleed again. Come down here. It looks like there's a big hematoma of some sort of lesion sitting on the left pelvic side wall this time. And now you can see almost different densities, like there's a higher density here and a slightly lower density here as well. And so you think, okay, that's not good, obviously. But now when you kind of come further up, you can see this kind of hyperdense stuff sitting here, coming a bit further up, a little bit of hyperdense stuff sitting, kind of layering on top of the higher density stuff as well. So exactly right. It looks like there is a left rectus abdominis muscle bleed, potentially coming from an epigastric artery. And unlike the last case, we do have contrast on this one. But this one has got, I mean, we do have contrast and we've actually got the points of bleeding, which is just here and a bit further up. And you know it's definitely points of bleeding because we've got contrast and that's what contrast looks like. And then because it's sort of like linear and sitting on top of the area of hemorrhage, it has to be sort of pooled blood, pooled contrast that represents blood in this particular situation. So you got someone who, yeah, maybe have had some previous bouts of pancreatitis. They've got some weird lesion located on their pancreas. May need to do further investigation for that. But actively right now, what we're concerned about, this person's exactly right. They've got a bleed located within their rectus femoris muscle. And someone's saying, could they be diabetic? Yeah, they could be. It depends on how long they're in hospital. Sometimes they get Clexane injections just sitting around, but they've got loads, don't they? Get here, loads of them. So yeah, potentially, maybe that's coupled with the pancreas problems. Who knows? but they are in a bit of trouble right now because they're actively bleeding from a rectus muscle hemorrhage there. So, and that's, I mean, I thought it'd be interesting because we saw a non-contrast hematoma with the acute injury, and now we're seeing a hematoma with contrast and some active bleeding on all in one phase, which I thought was quite good. Well, not good for the patient, but you know what I mean. Right, let's have a look at this one. And and I think this is bad, man. Was this one? No, no, this is the next one might be bad. Okay, let's have a look. This one was a young patient who came in with a headache. And you can tell straight away they're quite young because the lateral spaces are quite good. The sulcal spaces are good as well, so that's all good. Okay, let's scroll all the way down, all the way down, all the way down. I'll do one scroll through. Oh no, this wasn't it. This is trauma. I forgot to put the other one on. Okay, this is trauma. And actually that leads on to the next case. That's good. That's good. Okay, fine. Let's have a look. So this is a young patient. I think I remember there were 26, 27, something like that. RTA. Yeah, I think it was a motorbike. They're on a motorbike and they came in acutely injured, not doing very, very well at all. And as you kind of scroll down to this level, you feel like there's a bit of an asymmetry here. Can you see that? And that looks completely asymmetrical, doesn't it? So I think what bone windows are number three. Scroll up. So from the very, very top, keep coming, keep coming. Look, that's a proper depressed fracture. Push down like this. Coming down, you've got the frontal sinuses that look completely effaced. It's all coming this way. Bits of bone are actually, like that orbital roof looks like it's kind of displaced itself as well. That orbit doesn't look good, does it? Coming further down. The actual orbit itself, yeah, it looks like it's there. It doesn't look like it's been ruptured. You do wonder whether it's all kind of pushing the eye slightly outwards as well, coming as you come further down. And actually, there's fractures of the nasal bones. Can you see all that? It's not good, is it? It's just a bad situation for this person. So I always, I mean, it's not always useful. I mean, in reality, we're just going to say extensive depressed convoluted fractures of the left frontal bone, complete effacement of the frontal sinuses, displacement of the left orbital roof, potential proptosis, locules of air located within the orbital area. There's probably going to be fractures of the ethmoid sinuses as well because you see some air coming out there. And what's happened is that pressure pushed in and then back to some of that sort of lamina. I think it's papyri or something like that. That's what it's called. I can't remember. But what I always like to do is go mist, oblique, and then I just try and use MIP, put these slightly higher and window a bit, and it just makes it slightly easier to spot slightly more subtle fractures if there are any. And what you can do is just really manipulate things again and just make sure that you kind of, and if you keep your eye on here, you can just have a good look around and see if there's any other fractures anywhere else. And actually, I think it is that orbit, isn't it? That looks completely horrendous. It actually reminds me there was an MMA fighter a while back. I think they called him Cyborg. And I think, yeah, he got kneed in the head, and the guy was celebrating because the guy was obviously knocked out, and he was just lying on the floor with his face like this. And later on, it turned out they had these crazy facial fractures. I think that might have been the point where I was like, yeah, I don't know if I can watch this stuff anymore. Yeah, I just feel a bit sick. Anyway, so yeah, this is a really extensive fracture, and you can see it's very depressed fracture located. There's probably some direct impact over here. Actually, quite surprising. They don't look like they've got much in the way of a brain injury, but there must be a contusion. There just has to be somewhere. So let's go all the way down. Sometimes a contusion would just be on the frontal lobe. So what we could do is go sagittal. No, I can't 100% say I can see one, which is really surprising. Sometimes the temporal lobes, because what happens with the acceleration, deceleration, everything moves forwards, it hits the front. I mean, yeah, it doesn't look like their brain is actually too bad, which is surprising considering how significant that injury really is. Okay, good. So that one, not good. You know what I mean? Interesting case. But this same person, I think this is the same person, also had a CT scan of their neck. And is this the right guy? Make sure. No, it wasn't the same guy. Okay, fine. This is a different person. And it looks like we're doing a CT scan of their neck. And the neck could be really, really daunting. And you can tell this person's a young person, right? They've got very well formed bones. There's not much of the way of facet joint degeneration. And I always make sure I have a good look at that C1 vertebra. And these days, I am actually doing just doing these. Can I make that one? So layout one. Oh, you know what I should have done? I should have downloaded the images and then go layout one and done this. Okay, now bring it all the way up to the very top. I always make sure that I've manipulated the images so that I can see the full ring in one go. Because, yeah, you just don't want to miss a C1, C2 fracture. It's not good. It's just not good. So C1, I haven't got it quite aligned properly. So let's bring that there and then see if I can get that aligned a bit better. And there you go. You can see that. It's much better now. So it's going to be C1. It doesn't look like there's any fracture there at all. It all looks nicely aligned. And then you just want to have a look through the rest. So that looks nicely aligned. That looks nicely aligned. The next level, we want to straighten out a bit just to make sure everything's okay. Nicely aligned again, nicely aligned. So actually you're thinking to yourself, this person's done all right, haven't they? That they actually don't have anything going on. Lung apices was number 4. Lung apices, how do they look? Lung apices don't look too bad either. So it all looks like it's all right. So we could go away and think, yeah, that's fine. But actually, when you look at the anterior aspect of the C-spine and try and draw that line down, that does look a bit out of line, which is not great. This doesn't look great. And then this one looks very out of line, doesn't it? Yeah, so was it 2, 3, 4, 5, 6, 7? Yes, 6, 7. That disc space anteriorly just looks like it's been pulled apart, doesn't it? It just doesn't look normal. Like you can see how out of place. So you're worried there could be an anterior longitudinal ligament injury somewhere here. So if that's been pulled like that, that might mean that they've been kind of had hyperextension injury. So you've got to look and make sure that the facet joints on both sides are okay and there's no other fractures anywhere else. And the spinous processes, if they were to hyperextend like that, these things can crash into each other and end up having fractures. But that does not look right because now when you look at that, if we zoom in, it looks like that has lost a bit of height and a slightly sclerotic line just going along there. So you've got to be worried. There's got to be some sort of anterior longitudinal injury, maybe even an impaction fracture of some sort, or something's happened here. It doesn't look good. And so that's what we did is get the MRI scan. And I just thought it'd be interesting to show you guys. Osteophyte form. Yeah, you think so, right? Osteophyte, but this is a young person. And now when you look at it, can you see that there's definitely like a linear abnormality going along like this? There's actually probably a bit of a cortical break posteriorly going along like so. The anterior longitudinal ligament doesn't actually look too bad. I have no idea what's going on here. Probably got braces or something, don't they? Around this, a 2, 3. I mean, I assume that's 2, 3, 4, 5, 6, 7. Yeah, this is not good. So you'd be concerned there could be a posterior cortex injury here. Facet joints all look okay. Not much in the way of a hematoma. Do we have stir sequences? Muscle sprain, not much actually, not much of a hematoma. Spinal cord looks okay, but that is where the injury was, and that's definitely what's going on. So osteophyte, yeah, I know, I know why you'd say that, but actually, if we go back, I don't think I would buy that because they're young, and the intervertebral disc looks so abnormal compared to the rest, and then to look like there's kind of slightly more sclerotic line than with the rest. And in the context of trauma, I'd be concerned there's a traumatic kind of compression fracture there rather than anything else. And that was actually proven by the follow-up MRI scan. Right, cool. I think that is all our cases, and I'm actually, yeah, I can't believe we managed to get through so many. That's awesome. We've got through loads of X-rays, loads of CTs, a lot of trauma this week or this month. I hope that's okay. Thank you as always. Really appreciate it. I'm going to hand it back to Donish. He's going to tell us a little bit about Collective Minds or tell you about giving us feedback. Like I always say, please, please, please do give me feedback. I always try and do the best I can. I hope that comes across. I do want to be the best teacher that I can be, and I can only do it with your help. So please do give me feedback, good or bad. I can take it. I'm an adult. Just let me know what I've missed, not done well. It's fine. I don't mind. Just let me know. And as always, have a good month, and I'll see you on the next one. All right. Bye.
Thank you, Dr. Lasker. So I'll just be posting the feedback link in the group just in the chat box now. So please do fill that in. Any feedback is much appreciated. If you do want Dr. Lasker to review a case that you have yourself, and if you are a member of the platform, please upload that to the global community and just tag at Doc Lasker, and he'll be able to look at it during the next month's webinar. Thank you, everyone, and hope to see you next month.